Again, good morning. Mark Hunter with the Messer Financial Office out of Charlotte, North Carolina. We are today going to go into the basic underwriting. This would be pre-underwriting by you, the agent, so that you will have a better idea of the actual risk of that client and deciding the premium that you're going to use when we go into the quoting, which will be in just a couple of more weeks. Again, today, just before we get started, I want to make sure we do a couple of housekeeping items. First one always being, if you have the capability to mute your phone, make sure you do. You should be muted automatically by the system, but we don't want any side information to be seeping in. Also, we're going to ask that during the presentation, if you have questions, please use the questions section on the right-hand panel of your presentation to type in your questions so that I can address those based on time at the end of our presentation today. Again, too, this year, a little different than we've done in the past. Again, prior presentations we've done by allowing the carriers to come in and tell us how wonderful they are and how wonderful their products are. But that doesn't really help you sell life insurance. So this year, our focus is strictly on giving you tools that will enable you to do a better job, both in your presentation of information and as we dig down further, working with those clients and handling the objections. And then, of course, being able to write that life insurance application, get it processed, get it approved and issued, and of course, get paid. Now, one of the most important things that's always going to take place is the very beginning steps when you have the opportunity to meet with your client and give them a quote of the costs for the insurance. Obviously, it's very important that you do a very accurate job in that effort. So what we're going to do first of all today, take a moment here to do our very first polling question. If you'll put that up on the screen for us, Rebecca. And we're just going to take a few moments here to allow those that have signed in to answer the question. And your feedback, of course, is very welcome as it helps me get a better understanding of exactly if you're with us and what's going on. And of course, today what we're asking you to do is kind of give us a idea of how comfortable you are going into the underwriting process and determining the risk of the health of your client in order to make the determination on the premium that you quote. And we're getting some very good response today. Got about 90% of the attendees responding. I thank you. Perhaps some of those that haven't responded don't have the capability, aren't on a system that allows them to do that. So what we'll do here is close the poll at this time and review our results. What's taken place today, the greater majority have stated that you're just a little familiar with what goes on in the underwriting. Over 60%, in fact, have a little bit of an understanding. About 30% of you have what you consider a very good understanding. And then the balance, a little less than 10%, feel you have very little understanding. The important information that we're going to talk about today is what you've gathered in that previous conversation. Last week, we talked about using a basic field writing questionnaire. That was how you were going to gather the information on the client. And after you got all the basic information, their names, their dates of birth, the actual address of their home, et cetera, you started asking some health questions. Now, those of you that have been in the industry for quite some time, and perhaps in your past you were active in the health insurance sales at a time when underwriting was imperative for the health insurance, you had a lot better experience and knowledge of what your clients' conditions were when you went into the position of offering them life insurance. But unfortunately, in the past years, when we've had the benefit of insurance that did not require underwriting, which of course was a great benefit to the insured, but kind of made us in the industry as agents a little lackadaisical, or perhaps as new agents came in, they really had no familiarity of what was going on behind the scenes. So by gathering this information on that questionnaire, it's going to allow you to do a better job in estimating that premium. This will, of course, enhance your credibility with the client, knowing that what you talk to them about is going to be what they can expect to see from the insurance company, because that's all a mystery to them, what goes on behind those closed doors. It will, of course, most importantly, save you the embarrassment of quoting a lower premium and therefore establishing or building your client's hopes up for a more affordable premium. And this also, most importantly for you, will eliminate the objection that could come out in the presentation that the premium is now too high. So in other words, when you're presenting and you've got the numbers pretty close to where they need to be, you'll notice the comfort zone of your clients. And of course, then they'll take your application and you'll get into the processing. But of course, if you do come back and you have a higher quote or a higher cost to them, you are going to damage that credibility. So the quality of the information that you gather, the greater chances you have to be able to complete the task of underwriting by the carrier. You're going to make their job easier, and they're going to appreciate that. And it'll eliminate a lot of the times that they have to come back to you as an agent in your follow-up during the actual process and have you bring in additional information. So if you don't do a good job in estimating the rates, and the client does have conditions which cause their case to be declined, you have definitely created the most difficult situation for yourself and for your client. First and foremost for your client, because when that decline becomes apparent, it does go on record. And any future applications for insurance, the majority of those applications are going to have a question: has the proposed insured ever been rated or declined coverage? So obviously, if there's been a decline, you're going to have to acknowledge on that new application that they have. The reason I'm saying new application is because when you lose a case, the people are always going to ask you, isn't there something else we can do? And of course, as a salesperson, you want to make the sale, so you're going to offer to try again with another carrier. And of course, now that information is already out in the system. Whether you answer that question honestly or not, which obviously you should, has the proposed insured ever been rated or declined? The fact that they are declined is going to become part of the information pool that other insurance underwriters are going to become aware of anyway, whether you tell them or not. Worst case, of course, scenario would be if for some reason one carrier declined it because of a health condition, and another carrier, for whatever reason, missed that health condition and then went ahead and issued that policy, and then something occurred related to that condition that should have been discovered in the early format. The process of getting that payment made on the basis of that policy are probably pretty nil. So again, that information is going to be available to them. So you want to make sure that you're open and honest with what you present. Obviously, for you, the agent, you've made your job much more difficult when they do get declined. You'll have to do more research to try to find out if there is a reason that this condition could be treated more favorably by another carrier. But most importantly, of course, you've damaged that credibility that you had with your client when you proposed one rate and it came back not even acceptable. Or, of course, the possibility, and some of you may have already faced this before, where you went in with a preferred or even worse, preferred best rating, and of course it came back even at standard and the price was so much higher that the people can use that, and you're kind of boxed in when they choose to walk away from your offer because they say the premium's now too high. So again, the better job we can do in the very beginning, the more accurate we can be with what we predict, the better opportunity we're going to have less objections and also to close those sales. So again, all the time factors that come in your own best interest. So as we get started this morning, what we're going to try to do is the impairment risk that we're going to provide to you at the end is going to be a handout, but I am going to work with it on the screen. But first of all, let's start with our second polling question, if you would for me, please, Rebecca. And again, I'm kind of asking you a question before you've really had a chance to learn a little bit more about what's going on. And the question is, we've got a male that's 6 feet tall and he weighs 300 pounds. Do a guesstimate here. How do you think he'll fall? Do you think he'll be a preferred rating? Do you think he'll be able to possibly pass for a standard rating? Or do you think he'll be rated as high as a table C? And again, I'm asking that those of you who are actively out there with us this morning participate in the poll. Got a smaller percentage of you than we had as we started, so either you've had to go get another cup of coffee or you've got that secondary screen open and I've lost your attention span, which is always a concern. There we go. A few more people are waking up to the call. All right, so what we'll do here is we'll close this poll. And great job, everyone out there. First of all, no one thought that this 6-foot male at 300 pounds would qualify for a preferred rating. And that's great because I think I've been maybe harping on that quite a bit in these basic presentations, that I don't ever offer preferred rating to any of my clients, preferred best, even though they may be in wonderful health conditions, even though they may take no medications. I'm going to let them know that in the very beginning, that I'm not quoting them what would be considered the best of the best. Even though they may be there, I'd rather have them have that come back as a decision from the underwriter so that the premium I quote them today is greater than what they get back. Obviously, what I've done there is made my job much easier as a salesman. I don't even have to sell anymore. There's no tap dancing. They're happy that they got a better rate. And in reality, as I look at the poll and the answers that we have today, the greater majority of you, 70%, thought that this client would be table rated C. And that is probably where we're going to be with this client. And again, adding to that, the difference, the 30% that thought perhaps he might be standard. We're going to go on and give you an idea of that standard situation and why that won't be possible as I go into the actual risk guide. Again, today, this entire presentation is being recorded, so you can always come back in and listen. But most importantly, the documents that we're going to be using are going to be not available at this time unless you've been on the presentation with us. So what we want to do next is I want to get to the, oops, didn't want to go there. Sorry about that. I want to get down to our presentation itself. And I don't know where that came from. I'll get that out of the screen. And this is the medical risk guide. It's going to be 22 pages. And I'm going to skip right ahead at this point all the way to page 21, and we're going to come back and talk about other issues. Page 21 is the height and weight chart. This is a generic chart. It's going to be pretty accurate with the majority of carriers that you work with. There are occasions that we find that some carriers might be a little bit different, but not by much. I mean, I'm talking poundage. We'll go down and look at our guy here. He's 6 feet tall. I said he was 300 pounds. Well, as you can see from the chart, there's a possibility he might have come in at a table B, greater than 291, but less than 304. Again, though, with great caution, because you're not going to come into that house and work with that presentation and have a scale in your briefcase and ask them to get on it. Normally, when someone tells you their weight, they're probably telling you less than they actually are. The most difficult situations, of course, are the wife, because you're taking that questionnaire. Remember, we talked about this even a little bit last week. Guys are pretty open and say, hey, you know, this is my height. Guys have a tendency more often to cheat a little bit on the height than on asking to do less on the weight. Height does have a difference by just that bare inch, as you can see with this gentleman. If he were 6'1", he'd certainly be in the range for a table B. But he's 6 feet, we said. And where's that going to come from? Well, it's going to come from two places. Number one, if an examiner is involved, and I say if, only because so many of the companies today are doing a little bit more non-requirement of the actual paramed exam at different particular face values of the policies. We'll get into that more when we talk about some of the benefits of carriers, where I'm not going to do that today. But the basic situation with that height and weight, as we look at it and try to determine where it's going to come from, obviously it's on someone's driver's license. One of the things that takes place behind the scenes when that application is placed with the carrier, the first things they do is order that DMV report. Now, it's got two purposes. Number one, of course, it does have that information on their height and weight. Most importantly, that they're really looking for in that particular order is their driving history. Make sure that they don't have DUIs out there, obviously. Make sure that they don't have a reckless driving type of record. Even be careful with the speeding, because that can have an effect depending upon the conviction and the number of speeding offenses they have during a certain period of time. But all of that's information that they relatively have at their disposal without even having to worry about the examiner coming out. And they're certainly not going to base it just on what you say it is based on the application. Now, also on this particular chart that I'm making available to you, you will notice that it allows you to come all the way out beyond table J. Don't really see a K. You don't see an I. Okay, so just part of the process with underwriting, there's going to be these levels. I've taken this one, or given you the liberty to take this out all the way out to a table P. But I'm going to forewarn you that there are very few carriers that will get out this far on the table rating. Usually those that do, it's not going to be on your term products. It's certainly not going to be on your final expense products. It's probably only going to be on a permanent product and a higher face value permanent product are the few times you're going to see a carrier willing to carry their table ratings that far out. Usually you can expect that anytime you break that J line, you're probably going to get a decline. So I would be very concerned if I had that client that was 5'8", gave me a weight of 525. I know I'm borderline here. I'm going to probably be a J, but then I'm going to be concerned if he gave me that honest number of 325 and that there's a possibility of a decline. I would go ahead and make that very clear in the very beginning that you're going to do your utmost to find him coverage based on the height and weight standards that you have, but I would forewarn them and at least prepare them that the possibility is they might be declined. Now, again, looking at our table today, and hopefully most of you were with us last week, and you do have your health questionnaire of personal information, and you've got some notes on it. But we're going to go through some of these today. Let's start at the very beginning at least and talk about someone who has anxiety disorders, panic attacks, depression. Okay, so as we review it, the anxiety disorder itself, if it's slight, without hospitalizations, doesn't interfere with their ability to work or their outside social activities, no medications are taken, it's probably going to come in at standard. Okay, but again, with that anxiety and that panic circumstance, if there is a history of hospitalization, if it has affected their ability to work, you may see them rated as high as a table D. We get into the depression. Oftentimes, when you're getting the basic information again on this questionnaire, somebody's not going to tell you that they're suffering from anxiety or depression. The reason you're going to find out is you're going to have asked that question about medications. So even though they don't tell you that they have the condition, if you've done your due diligence, if you've asked them about prescription medications, and then as we talked about last week, gone over to that website for RX, looked it up, or maybe you just type it in into the find information and you'll find out what that medication is used for, and you'll find out that it is used in the cases of depression. So, deeper situation with depression, loss of work again, if there's any psychotherapy involved. Again, fluctuation could be standard, could be as high as a table F. Now again, you're not going to be the underwriter, so you're not going to have all the pertinent information to really figure out where they're going to fall. But the odds are you can tell that it's not going to be a standard rating. Someone who's had no hospitalization, no suicide attempts, again, they haven't lost a lot of time at work. We've opened up that table rating all the way down to a D now to an F. So it's kind of like our halfway point. They are continuing to go in for psychotherapy. And as it says, there are cases that it could get to be a non-insurable condition. Now, what do you need to do as an agent to help this underwriter make yourself obviously more professional? Again, with this guide, you're going to know that you need to ask that client about the diagnosis, ask about the number of episodes that they've had and when that last one was. If it is a depression, has it been prescribed as a bipolar or manic type of depression? Was the depression perhaps just related to a specific event? It's not unusual that you'll work with a client that lost a spouse. They've gone into a state of depression related to that event. They are on a medication to help them better deal with that depression, but it probably is not going to be life-threatening, nor is it going to be long-lasting. They're just going to need some time. So again, you gather the information, you find out that it is an event that's been recently diagnosed due to the loss of a spouse. That's going to be information you're going to provide on that application because believe me, the work that you can do here and dig in deeper yourselves is work that's not going to happen when that examiner goes out and asks about their health history, asks about their medications. If you ever find an examiner that does the extra deep digging for you, that's an examiner you want to make sure you call on in all your future cases so that you get accuracy the first time in the door. But what I'm saying to you is I find myself able to do a better job of identifying conditions that exist than does the person that's being paid to go in there and do this by the carrier and bring it to their attention. The carrier underwriter, of course, is going to discover what's back there in their due diligence. But again, if you as an agent can start allowing yourself to be recognized by underwriters as a person who does their own due diligence, makes their job easier, you're going to find that they're going to work with you a lot closer. Something you need to understand about underwriters, I mean, it's a profession, okay? They've taken time, they've been educated, they've interviewed, they found a job with a carrier. Maybe they've done such a good job, they've moved up the ranks in that underwriting and they become a supervisor or a master of underwriting, and they really do the final check on everything that goes through. But bear in mind, this is a profession. They're going to be paid not only to do their job, but to do their job in a fashion that's in the best interest of the carrier. So if an underwriter does not do a good job in their discovery work and allows cases to go in at ratings that should have been higher than they are, obviously making for a smaller premium than it should have been, at some point in time, they're probably going to be cut loose. So their jobs are on the line to be as accurate as they possibly can. And they're going to try to do that, obviously, to keep their job. Okay, if again in our questions, we need to find out were there hospitalizations, were there treatments, how often, when were they? Again, we've asked about the medications. Again, if we've done our job right, we've asked them how often they take it. If they took a medication and they no longer take it, that can happen. Make sure you get the dates so that if they have been diagnosed and then now they've done an improvement and the doctor has said, okay, I don't think you need to take the medication anymore, that is going to be part of that APS report. Not because they just decided they didn't need to take it anymore. And believe me, I've run into those situations where they say, oh, I used to take this, but I don't need it anymore. So right away I asked them, well, did the doctor tell you you don't need it anymore, or did you just self-diagnose yourself and decide, hey, I don't need that medication anymore? Well, that is the worst of circumstances. When a client chooses not to take medications that were prescribed, it's going to be rated as medication abandonment. That is a tag that you do not want your client to have on that case. Medication abandonment in most cases is going to mean that underwriter is going to decline it. They're going to decline it just on that fact, based on the fact that that client doesn't think they need to take those medications when a professional has told them that they should. So worst case scenario, diagnosed, prescribed, not taken by choice, and then tagged abandonment. If they've lost time for work, you want to find out how much. Again, when we're talking about the cases of depression, if they are seeing a psychiatrist, how often. If you can attain at that time the names of the facilities that they are going to, uh, that will allow, again, the underwriter to go ahead and request those APS. Sorry for the acronym for those who don't recognize it. It's the attending physician statement, APS. Very common, again, that an underwriter will use that. And since I'm talking about an APS, I also want to make your job easier and let you know the attending physician statement can greatly delay the process of an application. What happens is, first of all, when you did an application, you should have had the client sign a HIPAA document, allowing them, the carrier, permission to do the necessary investigation in order to determine the true health conditions that exist. But here's what can happen. You have that particular document done, and the underwriter requests from that physician that APS, and the physician's facility, and I'll give you a true home-based situation, happens to be Novant here in the Charlotte area. And Novant says, well, that's fine that you've got your HIPAA document, but we want our HIPAA document signed. So they tell your carrier that. Your carrier puts that up on your notes. You have to go out there and get that document, get that to your client, get it signed, and get it back to the carrier. So obviously you can see we got a delay going on right there. Don't think you can cut it to the quick, because I've tried it myself, and say to the client, we'll go into your doctor, sign their release, and we'll be okay. Nope, won't work. Even if they sign the release, you need them to get that signed document, that wet copy, back to you to send to the carrier, because the doctor's office is not going to send it to the carrier for you. Okay. Now, let's say we do that in a very good, rapid format and do it in 7 days. And believe me, if you can do that in 7 days, you got some quick turnaround. It's probably not going to happen. So all we've got at this point is permission to get the records. Again, I'm going to use the Novant system because that happens to be an area that I happen to be stuck with here in the Charlotte network. It used to be I could pretty well expect that from the time that doctor got that request from the carrier, about 30 days for that doctor's office to get it back to the carrier. Now, also for your information behind the scenes, this isn't free. Each facility charges for that information, usually based on a cost per page. Obviously, the deeper the records that exist for the patient, the more pages are going to be there, the greater the cost. And that fee is paid by the carrier. So again, you're not seeing this going on behind the scenes, but the carrier is paying for that information. Some physician offices will not release any of those records until they get the check from the carrier. So, carrier gets back that HIPAA document. They send it to the department within that allows them to communicate with the doctor's office what the costs are going to be to send them the check. Can we do this in another week? Well, let's hope so, but So where are we at now? We're already 2 weeks before the doctor's office is even prepared to release the information. Well, in the old school, doctors had records right there on site, and they would send their administrator to the file, and the file would be copied, scanned, and sent off, and that would be wonderful. Well, that doesn't happen today. What happens today is a professional organization comes into that doctor's office on a scheduled basis, downloads all of that information for them, and creates the cloud and the records that are going to be kept secure, again, because of the HIPAA information here. So it's really secured and kept off-site. That means that the doctor's facility that's been requested the information now has to request that information from the third party. Yes, I'm sure some of you are starting to laugh now, because what also happens is they decide that there's a certain day of the week that they order that. They don't just do it because they got it. So now the doctor's office has got this order. We're already 2 weeks in. Let's say it's Monday, and they don't like to order those until Friday. Well, there went another week. It's sitting out there before it even goes to that third party to get the information. So they finally send it out to the third party, and we said it's Friday, so you know they didn't do anything. Got to the third party on Friday, perhaps on their system. Perhaps someone gets in that office on Monday and is going through those, and perhaps their work schedule or their load is such that they're not going to be able to get to it until Wednesday or Thursday based on the requests that they have. And let's say they do get it done by that time, and they send it finally on to the carrier. So now we're already at 4 weeks, and the carrier doesn't have the documents to even look at to make a determination. I always forewarn my clients that if an APS is going to be requested, they could expect the underwriting time to have been extended by about 30 days. I want to work in my own best interest here. So normally what I'll say to a client, if everything goes well, top to bottom, don't need a doctor's APS requirements, health history and information is relatively available. Realistically, from the date I get this application into the carrier, I hope to be able to get back in front of you in 30 days with an offer for you to look at. However, if again, the information that's discovered takes the time necessary for them to do their discovery, and another 30 days is added, I'm just saying to you, this could take 2 months. Okay, so back to my displeasure currently working with Novant. And I only again repeat this information because I actually have a case sitting under these horrible circumstances. For whatever reason, Novant tells me and the carrier that it'll be 60 days before they get them the information. So I don't know if they're overloaded. I don't know if they're understaffed. I don't know if they're having a disagreement with the cloud company that they've hired to hold the records. I don't really know what's going on behind the scenes, but I've had to inform my client when he already had to jump through hoops to get them the right questionnaire formula to use for the HIPAA, that unfortunately I can't get him coverage for at least another 60 days. Wow. In the past, I'll be honest with you, I am not an agent that likes to take a check with an application. Now that might shock some of you, but that really has been the way I've done business. Told my clients, hey, we're going to get an app in, we're going to get a determination, we're going to get an offer back. If you like the offer, you're going to accept it. I'm going to bring you a policy. You're going to pay the premium, and you'll have coverage. Well, I think the experience that I've just found myself in has recertified in me using the conditional receipt going forward if I'm going to deal with clients that I know in the Charlotte area are probably dealing with the Novant Health System. And of course, that's going to all be in the client's best interest. The conditional receipt, if you are aware of it or not, is the manner in which you as an agent are representing the insurance company, accepting a premium in advance of an underwriting decision, which is giving that client temporary coverage, meaning that God forbid something should happen to the client prior to the completion of the underwriting, that they would have a death benefit available to their loved ones. Now, of course, that's not going to be a quick, easy exchange. However, at least that guarantee is there, better than having to put them off for another 30 days. And I do know from experience, and again, working with agents, because of the delay in time and all of the work you've done here to get paid, possibly taking 60 to 90 days is one of the reasons agents prefer not to get into the life insurance business. But you just got to accept the fact that it is part of the way things work. It's a great way to make a living, but you do also have to have some patience. Okay, so let's go on and take a look here a little further. I think we've beat up the anxiety, depression order enough. Arthritis, a number of different cases of arthritis. Take the time to look at it, and obviously, again, when that comes up, find out what type. Again, ask the right questions that we've given you the ability to do. Get all the information that you need and have it available when you turn it in. Asthma, believe it or not, can have an effect on the actual table rating. The more severe that breathing difficulty is, the more at risk they're going to be, even to the extent of being a decline. Of course, a lot of people at this time of year are suffering from asthma. It's a seasonal type of situation. So you want to make that note if that's the case. You want to say, hey, no, they're not on a prescribed medication, even though they've seen their doctor. They're just taking an over-the-counter type. And if they are, what they're taking and how often, versus if they're taking oral steroids. So again, the more information you gather, the better the guesstimate will be. We'll get into cancer. Cancer can come in a number of different stages. You want to know what type it is. You'll find that in the questions again. You'll also find out that under certain conditions, we're going to talk about extras per thousand. I'm not going to get into that today, but I'll be giving you some lessons on how that works as well. That's going to affect that actual quote. Another type of cancer. Again, things that you're going to definitely run into today. A lot of steps and stages here of cancer. Even the basic melanoma type of cancer, pigmentation of the skin. Again, taking a look and seeing what's going on. More and more today you hear of this. Of course, more and more men are becoming cognitive of it and getting the proper checks made. Those that don't, shame on them, because this is something that can be prevented when caught early. It makes a difference. I unfortunately am aware of 2 agents that I've worked with here out of Messer in the past. One who was diagnosed and it was already too late. It was already into a stage 4 situation. That agent unfortunately is no longer with us, versus another agent that was able to find this in a very early stage, received the necessary treatment, and feels, as good as new. So very important that men recognize the need to go in and get those checks done much as they find them embarrassing and don't want to do it. Any other types of cancers, so you can get some information. You're not going to get all the answers out of this book. When you do run into circumstances and you feel you've done your due diligence, but you're still wondering what are the answers, of course you'll be able to find those out. Give us a call. Let us assist you there. And if it's something that's deeper than I can assist you with or anyone else here, we're going to carry that over to an underwriter and get a pre-underwriting decision. Cholesterol issues. Going to hear about the COPD. So again, all of these things that are coming in. Coronary heart disease. Again, this is going to give you a great list of information of what you need to ask about and the effect that it could have and the medications. This one even gives you, as they all do, give you an example. You have a heart attack of a gentleman at age 50, 2 vessels, taking Lipitor, chest pains back in April of 02, had a stent put in. All this information that you can provide to the underwriter in advance, if you can, is going to quicken the process. More information on the heart and heart valve disorders, etc. Very common today, you'll run into more and more cases with the irritable bowel syndrome. Definitely run into the Crohn's cases. Again, Crohn's treated early can be taken care of without surgery. As it gets more progressed in different stages, it may require surgery. Might go even further and require complete removal, which of course could or could not have an influence on making it more insurable actually with removal than suffering from the disease without. MS. And again, I hope that you'll find this guide to be very, very good for you and assisting you with this. Epilepsy and seizures, TIA, types of strokes available, other impairments, and didn't want to get this far. Rebecca, let's go ahead and throw up that third polling question if we could, please. Okay, we're asking you today if you have a client that says they're diabetic, which do you feel would be a higher rating, if they're a type 1 or a type 2? And we're moving along very quickly here. That's good. A lot of people are still paying attention. Greatly appreciate that. We are winding down and getting closer to our 9 o'clock hour, so we'll be finishing this up very soon. And we've actually had our highest response today of the attendees on this poll. So we'll go ahead and close the poll, and you'll recognize that we're pretty well split here. 55% feel that a type 1 diabetic condition will be a higher rating than a type 2 at 45%. And I don't know where I missed it because I should have seen it here. And I might have to check my documents, but we should have had a page here that followed cancer and cholesterol and diabetes. So I'm wondering if we didn't miss a page and I might have to have this redone. Going back to my original documents here. So, coronary heart disease. Yes, there are. There's unfortunately a group of pages missing here. Diabetes is missing. EBCT, electronic beam computerized tomography, is missing. That's not one you're going to run into a lot, obviously. We did have the heart murmurs, but we're also missing hepatitis. So I do apologize. Apparently a number of the pages got missed in this documentation report. I'm going to have to get this redone and get it to you. But let's, of course, talk about the diabetes, the purpose of this last polling question. Type 1 diabetes usually occurs in the younger years. If there are no histories of complications, if the onset was within the last 5 years for a person under 50, the ratings are going to range between an E and an H. If it also goes all the way back 25 years, it could be again from H to as high as that L, which of course, once we get into that L rating, we're potentially looking at a decline for most carriers. And at ages 50 to 79 with onset within 5 years, B to D. So let's kind of stick in that area, which is more realistically going to be the case. The type 1 diagnosed in a younger age, and they're already up in age to 50, obviously surviving that issue and getting that table rating of a B. Kind of keep that in mind. Over to the type 2 diabetes, which is a non-insulin, still having that insulin resistance, so they're needing medications that you'll hear about. Primarily the most common one is metformin. If they have this with no complications, the onset again was within the last 5 years. They're under age 50. They're probably going to be a table C to F. Usually the type 2 diabetes gets diagnosed with people over age 50. Again, with an onset with less than 5 years. There is even a possibility of standard. I would never quote standard when I'm talking to someone that has diabetes. Excuse me, I had to take a break there, a little thing in my throat. Anyway, I would never quote standard. I primarily start at table B with diabetes. So if we have that situation and we have the knowledge that we're going to use a base of a table B, and let's say that we've also got high blood pressure involved. That one's relatively easy, but then again, not. And the reason I say that is if you unfortunately have a client that has been diagnosed with high blood pressure very recently, and by recent I mean, like within the last 90 days, even though they've been diagnosed with it and they've started treatment with some basic medications, because that high blood pressure was recently diagnosed, many times they're going to get declined on that initial application. What the underwriters are going to want to see is an attending physician's report down the road, greater than 90 days, that shows that the medication has stabilized them to the point that the blood pressure is in control. So now over 90 days with medication under control, we could almost in many cases stay at a standard rating, so no increase. Let's look back though at cholesterol, and the reason I'm trying to do this is to get us to the point that you understand when you have a table rating, and we've said we've had it with this diabetic client, we've got the blood pressure issue, and we've got the high cholesterol. Each one of these start adding on. You don't just stay at a table B, because the cholesterol issue that they have and the readings they have is also going to rate them up higher than a table B. You've got to add that on. So if we're at B and we're going to add on, let's just say for the safety purposes here with the blood pressure and the cholesterol, 3 more table ratings, we could go all the way up here, C, D, E. Shocking, because when you quote E, you're going to see a heck of a lot higher quote than you did at standard. Now again, depending upon the condition, depending upon the medications and the treatment, depending upon those medications bringing things into control, we might again get ourselves back into a better position so that they don't rate them at all, other than rating them on the diabetic situation in the table B. So the more health conditions, the more issues obviously that a client you're working with has, the higher that rating is going to be, going to compound them on them and come up with that higher number that you're going to plug into your quoting tool, which we're going to get to shortly. And then with that in mind, I want to take us to the last portion here today, and that would be talking about Messer Financial and our assistance to you here. We would ask that if we can, in the future, that you would give us a call. Next week, we're going to close off the education process for just 1 week. Going to come back to you at that time and show you the field fact finder. That's where we're going next. So you're sitting in front of your client and you're going to do some more discovery work than you have on the health issue. Hopefully you've answered a lot of the health issues in a phone interview prior to your appointment, but you might wind up doing the questionnaire. You might get the basic information and do a fact finder, and then you might come back with the fact finder and go ahead and, oops, sorry, I lost this, and come back to the office to really do your quoting. Again, here we are. We're asking that if during this time ahead you want to give us a call, our basic 568 number here, any of the extensions to any of our guys that are currently working with you as the marketing representatives, and of course myself, Mark Conter at extension 713. We wish you a blessed holiday season. Happy Easter. And we'll be back with you 2 weeks from today, 19th to 26th of April. We're going into the fact finder. I think the last but most important thing also on the screen, you see in the corner the Adobe emblem. That is your medical risk guide. I'll leave this up here on the screen for a few minutes before I disconnect. I will say good night to you all. Good morning. Have a great holiday season. Download that Adobe file. Keep it, save it in a format, but we'll get it repaired for the missing pages that I apologize were not a part of the presentation today. Thank you very much. Mark Conter signing off.